Hi, I'm Frank Peacock. I'm an emergency physician. I've been doing that for about 25 years. Did a lot of work in the cardiovascular space. Was able to change the delivery of cardiovascular care, which has prompted us to the traumatic brain injury side. I'm the PI for the HeadSmart 2 trial, and this is going to have the same effect in the world of traumatic brain injury in terms of changing the standard of care. So we know that about a third of patients who get a negative CAT scan in the emergency department will have microvascular hemorrhage on their MRI. We don't MRI most of these people today, but those patients have much higher risk of adverse events, higher rates of post-traumatic stress disease, higher rates of depression, greater rates of suicidality, panic attacks. The downstream dysfunction frequency in that population of patients that we don't identify today is markedly significant. This represents the cohort for change where we have an opportunity to improve the outcomes for those patients. What is unique about the way that we are investigating and attempting to change the care of traumatic brain injury is that historically we've done one little marker and we've done one little change. And the trouble with the brain is that just isn't going to work. We've done a whole bunch of single molecules and that they don't have the information that we need to have. It's going to require a multi-marker strategy. And unlike the heart, which a marker is good enough, measurements of function are necessary for the brain so that we will have a unique implementation of data, both functional and physiologic, which is what it's going to take to advance brain science. Currently, we send people home and they tough it out on their own. What this will allow us to do is to identify populations of people who 30 days, 60 days from now will have bad outcomes. And by bad outcomes, those are people we could intervene and prevent. Without the prognostic component, we don't have that opportunity. Where traumatic brain injury is going is an evaluation that we don't do today that needs to be done. We can prove it needs to be done. We can show that patients who get that evaluation have better outcomes, but we can't do it on everybody currently. And so that's the value of the functional and physiologic testing done simultaneously, is we'll identify those patients who will benefit, and that's going to be the driver of therapy. As doctors go to medical school to learn how to make patients better, and this is going to help them understand that and identify those patients they can help.